Good afternoon. I'd like to thank Ketotic Hypoglycemia International, and particularly Danielle, for the opportunity to talk to you about what is ketotic hypoglycemia. Ironically, I began my career asking this exact question. When I was a fellow, which is a person in training to become a pediatric endocrinologist, I had the opportunity to see a 2-year-old who presented to the emergency department with a 2-day history of vomiting and diarrhea. The patient had been referred to the emergency department for IV fluids because the pediatrician had been concerned that the child was dehydrated. When the IV was placed, plasma glucose was checked, and it was found to be 2.1 millimoles per liter, or 38 milligrams per deciliter. Well, I was an overzealous fellow, and I wanted to figure out what was causing this child's hypoglycemia. So I did an extensive workup of testing for hormonal and metabolic causes of low sugars. Later that day, the senior pediatric endocrinologist at Boston Children's came to see the patient with me, and he scolded me. He said that the patient had ketotic hypoglycemia and that no evaluation was needed. He subsequently gave me an article that had just been published, and in that article it said that an extensive and overzealous workup for an endocrinopathy or inborn error of metabolism is not necessary in a 1 to 5-year-old who has hypoglycemia and ketones. Well, the workup had already been done, and the test had been sent, and then 2 days later, the workup came back showing that the child had MCAD, a medium-chain fatty acid defect. MCAD is a potentially fatal disease, and it bothered me that one of the leading pediatric endocrinologists in the United States had missed a potentially fatal disease and called it normal. Because of this, I became fixated on trying to understand hypoglycemia. I had many questions. Is hypoglycemia normal in the setting of fasting in children? Why is everybody dismissing hypoglycemia in children as normal? The second question was that since fat breakdown should occur in the setting of hypoglycemia, and fat breakdown should lead to formation of ketones, as you heard from Terry Dirks, how does one differentiate between ketotic hypoglycemia and other potentially pathologic etiologies? I became so fixated on this question that I started to do research on this, and this was a study that was done from 1998 to 2000, and it was looking at hypoglycemia found in the emergency department setting. To do this study, we had a computer program that was created called Real-Time Recruiting. The program was created by Atul Butte. And the program would search the laboratory system every 2 minutes, every day for 365 days a year, and it would pick up low sugars of under 50, 2.8 millimoles per liter. When the program found these low sugars, it would page me without any human intervention, and so I would know within minutes of the sample being run that a low sugar had been documented, and I could call the emergency department and seek permission from the families to do testing to figure out what was causing it. Well, this system allowed me to capture all the low sugars that occurred, and it allowed the testing to perform without any knowledge of what was involved in the child's history. But what you could see here is that hypoglycemia is extremely rare. Even in children who are presenting with vomiting and diarrhea and children who aren't eating because they're sick, low sugars were documented in less than 1 in 1,000 children. There were 52,189 emergency department visits during the course of this trial. Of those, only 40 children were found, incidentally, to have a low glucose under 50. We were able to get 32 of the 40 to consent to the study, and we did endocrine and metabolic workups on those children, and what we found was that 3 children had endocrine causes of hypoglycemia, and 6 of them had fatty acid defects. I'd like to point out that this was the era before fatty acid defects were screened for on newborn screening, and so we had a higher rate of fatty acid defects than would probably be seen today. Well, This study allowed us to identify the cause of hypoglycemia in about a third of the patients, but that left about 2/3 of the patients still with ketotic hypoglycemia. I began to question, well, is this normal? But there were some clues that maybe it wasn't. The first clue was that if a child had ketotic hypoglycemia, that child had over a 50% chance of coming back to the emergency department within 6 months with another episode of hypoglycemia and ketones. As aforementioned, hypoglycemia was extremely rare, and it was the same children coming back over and over again. Another clue that maybe this was not normal was that there was a predominance of males in the population. If this was a normal condition for all children, why did ketotic hypoglycemia occur in boys more frequently than girls? I'd like to point out that this male predominance has been seen in every article that has been published over the last 50 years. And this was an article that Terry Dirks and I and our teams wrote in 2015 looking at ketotic hypoglycemia. And you can see the male predominance, which is approximately 2 males for every 1 female. Well, I hypothesize that maybe disorders of glycogen storage or utilization could be causes of ketotic hypoglycemia. And in particular, there were 3 types of glycogen storage disease, GSD type 0, GSD type 6, and GSD type 9, that only involve the glycogen pathway. These defects would result in low sugars, but because gluconeogenesis and fatty acid oxidation were intact, the children would develop large ketones. And we questioned, maybe this was part of ketotic hypoglycemia. Well, the results of this study were published in 2015 in the Journal of Inherited Metabolic Disease, and I will refer people to this if they have questions or want more information. As part of this study, we required children to have 2 or more episodes of ketotic hypoglycemia, which again was defined as under 2.8. They had to have normal endocrine evaluations and screening for growth hormone deficiency. They had to have normal negative screens for fatty acid oxidation, either on newborn screening or on testing performed by the doctors. We also wanted children to have normal liver sizes because we knew if there was a big liver, that would increase the chances of a child having glycogen storage disease. We also wanted to capture the classic ketotic hypoglycemia population. To avoid potential bias in our recruitment, we elected to collect samples from outside our institutions. All the samples had to be sent to us by doctors who had children with ketotic hypoglycemia. We did not use any of our own patients. That way we could not bias the results. As part of the study, full sequencing was performed of the genes for GSD 0, 6, and 9 that you see listed on this slide. I would like to point out this was the era before modern technology, and so we had to sequence each gene individually. The sequencing was performed in both the forward and reverse directions, and we performed duplicate testing to ensure that the findings were real. Once we had genetic differences, they were run through the known databases, which included SIFT, Polyphen2, Mutation Taster, and the NIH database, to predict if the mutations, if the DNA changes were pathologic. In order for a person to be called as being positive for the condition, all of the programs had to say that they were pathologic in nature. The study ran from 1998 to 2013, and during that period, we had 177 samples collected from children with ketotic hypoglycemia. Not surprisingly, there was a male predominance with 105 males and 72 females in the population. But when we reviewed the records of those patients, there were 13 patients who had not been diagnosed as having a big liver, but had histories that were possibly consistent with it, where on the reports it said that there was a distended abdomen or an enlarged abdomen. So to keep this clean, we excluded those 13 patients who possibly could have had liver enlargement. I would like to point out that all 13 of those patients were confirmed to have glycogen storage disease, 5 with GSD type 6, 7 with GSD type 9, and 1 with GSD type 3. That left us with 164 patients who had classic ketotic hypoglycemia. When we did the sequencing, we found genetic changes in almost 29% of the subjects. 20 of the people had changes in the gene for GSD0. 8 of the patients had changes in the gene for GSD type 6, and 19 of the patients had changes in the genes for GSD type 9. I'd like to point out that there were also 2 patients who had changes in 2 of the genes, where they had 1 mutation in one gene and 1 mutation in another. Classically, those would be considered normal because you need 2 mutations in the same gene, but we now know that those children also had pathology. It's called synergistic heterozygosity, and Terry Dirks and I have published on that since this article. Well, when we ran it through the computer programs, all of the programs agreed that these were pathologic in 4 of the patients for GSD0, 2 of the patients for GSD6, and 14 patients with GSD type 9. What is interesting about that is that GSD type 9 is an X-linked disorder, which means that it's more common in males because males only need 1 copy of the abnormal gene. And if you look at this, of the patients that were confirmed by all the programs as having the disease, you can see that there was a male predominance for GSD9. And we think that this may help explain why ketotic hypoglycemia patients are more often males. So to summarize, the ketotic forms of glycogen storage disease appear to be an under-recognized cause of hypoglycemia and a subset of the patients with ketotic hypoglycemia. In my opinion, ketotic hypoglycemia is not normal, and it is likely due to unrecognized pathology like GSD, and you will hear today about other causes that have since been identified. And I think that these are just unrecognized causes. It's not a normal condition. Until we have answers, I would like to end with a final message. We need to treat the patient. Hypoglycemia is not normal. Ketones are not normal. And we need to treat the patient even when we cannot explain what the cause is, because treating the patients will prevent the episodes and the patients will benefit. Why is this treatment so important? Well, if we treat them, we're going to prevent hospitalizations and emergency department visits. What's already been shown is that when you take a child with ketotic hypoglycemia and you treat them with cornstarch and you treat them with protein, it improves growth. It improves stamina and allows children to participate in all activities. It improves bone density because the chronic ketosis can cause osteoporosis and weakening of the bones. And it also improves school performance. There was an article in the Washington Post about one of the patients with ketotic hypoglycemia that was diagnosed with GSD9. He was struggling in remedial classes and failing out of school before the diagnosis. But once he got put on treatment and we prevented the low sugars, he became valedictorian of his class. And finally, while most children with ketotic hypoglycemia do find there's a small risk of cirrhosis from the chronic irritation to the liver from the ketosis, and treating will prevent that. I'd like to end by thanking my team over the years. I was very fortunate to have the world's greatest team working with me and supporting me while I was in academic medicine. I lived truly a dream in the 30 years that I was practicing medicine, and I was able to see a disorder like glycogen storage disease go from one where children were dying or ending up with liver transplants to one where we did gene therapy and saw people come off treatment. My one regret is that I was never able to get the medical field to take ketotic hypoglycemia seriously. But I hope, And I believe that Ketotic Hypoglycemia International will finally bring the attention to these children, and we're finally going to get answers into what's causing it. Thank you very much.
Hello, David. I am so excited to be able to invite you to this Q&A, and thank you so much for attending. How are you?
I'm doing great, and it's wonderful to be here. And Danielle, congratulations on the creation of this very important organization.
Thank you so much, David. And we are just so excited to have you here. And I just want to say on behalf of our community, thank you so much for being here. And just a quick note from the families. They miss you so much. You are missed. Yes, and now...
And I miss them also.
Thank you. I'm sure they are happy to hear that. So now I am moving on with some questions from the audience. The first question: what blood sugar level or ketone levels is the limit for a child to be considered as suffering from ketotic hypoglycemia?
That's a really good question. Despite all the technology that we have, we still have a very difficult time defining what is normal. Now, you're going to hear tomorrow a talk by Kamal, one of our fellows from the University of Connecticut and Connecticut Children's, about a study we just completed looking at ketone formation. I don't want to steal her thunder, but you will hear that ketones are not running high in most children. And while ketones are a normal phenomenon, as you heard earlier today from Terry and from Paul, it's very rare for children to have ketones over 1. And in my mind, it's unusual to have, in a normal situation, ketones of even 0.5. So it's different when children are ill, but in a normal, healthy state, children should not be getting ketones that are moderately or significantly high.
Thank you so much for your reply, David. And I have one more. For a child diagnosed with idiopathic ketotic hypoglycemia, can they still have episodes of blood sugars that go above 300 or remain high for hours after eating?
So high blood sugars can happen for 2 reasons. One reason is simply because the body does not like hypoglycemia. The body has multiple pathways and multiple hormones, all designed to keep the blood sugar normal, because the brain depends on blood sugar delivery. And so as you saw earlier today in one of the talks, when blood sugars fall below 70 or 3.8, you get secretion of glucagon, you get secretion of epinephrine, you get secretion of cortisol, growth hormone. And so big stress response trying to raise the blood sugar. When a person gets glucose, it's common because the body's trying to raise it to overshoot. And so one cause of the high sugar is just stress response. But that is not normal. If the body is so stressed and can't raise the blood sugar and it goes to 300, that should be a warning sign that something is not right, because the body's trying to raise it. The second cause of a high blood sugar is glycogen storage disease type 0. So in glycogen storage disease type 0, the blood glucose can't be stored as glycogen. And as a result, when a child eats, there's no place to put it in the liver. And so the blood sugar should be high. So in my mind, we can see that really high level sign of pathology is existing.
Thank you so much, David. And I can just tell you that the questions is just dumping in. We have a lot of questions for you. So I will move forward with the next one. Should all IKH patients be tested for DSD, even if the liver doesn't appear enlarged?
So I think the most important thing we can do is a good history. Yes. Doctors have forgotten how to practice medicine. No offense to the doctors here, but we're so dependent upon ordering tests that we forgot to talk to the patient somewhere along the way. Before I would work up somebody for glycogen storage disease, I would start with a history. All children with glycogen storage disease have some common features. They're irritable in the morning. They have to eat immediately. They oftentimes will have ketones, well, they should have ketones in the morning. If a child does not have ketones or hypoglycemia in the morning, I wouldn't be pursuing GSD. We're going to hear in this conference there are other causes of idiopathic ketotic hypoglycemia. But if someone has hypoglycemia or ketones in the morning, GSD should be considered.
Great, and I will just thank you so much for that reply. That is a frequently asked question in the KHI support group. And I will just move forward with actually a personal question from me. Can a family who are carriers of GSD, can they be symptomatic of ketotic hypoglycemia? We are seeing a lot of these families stating that they have been confirmed carriers, but they can't get a GSD diagnosis because they are only carriers.
So one thing I learned in my 30 years in medicine was that oftentimes the textbooks are wrong and the field is evolving. The textbooks say that carriers don't have symptoms, but I don't believe that. And we hear all the time that the carriers who have manifestations, that it's not on or off or black and white, that everything's a spectrum, and that carriers probably have 50% enzyme activity. And if they are fasting or they're too active, they're going to have symptoms also. We also see this in many of the mothers who have a child with ketotic hypoglycemia. During pregnancy, they were having problems, and because they were getting hypoglycemic products. So absolutely, I believe the carriers can have symptoms.
Thank you so much, David, because this occurs in a lot of the families where the ketotic hypoglycemia runs in generations, from grandparents to parents to children. So it's a very frequently asked question, and I'm so thank you for you giving this reply. I think it will be a huge relief for a lot of the families. So now I have a question, and you might find it a bit hard to answer, but the question is, how do we get the medical professionals to take this seriously when we came back with negative genetics?
So if I have one regret over the last 30 years, it was that I could not get more doctors to take this seriously. But times are changing. The first thing is this organization is going to make that difference. Individual doctors were powerless to get the field to change. But ketotic hypoglycemia is making a difference. And I believe this is going to be the key to getting the medical community to pay attention to it. You also have other doctors out there like Terry, Dr. Dirks, who also saying we have to treat the patient. We have to treat what we call the phenotype. Don't just treat the genetic type, because there are still things we don't know. And studies continue to show that when genetic testing is done and it comes back negative, there's nothing there. Recently, there was a study done at MIT, one of the leading organizations in the United States, and they went back and looked at people with genetic testing called normal. And I went back a couple of years later, because they found diagnoses in about 32% of the people. So treat the patient, and eventually the doctors are going to also pay attention because of their age.
Thank you so much for that reply, David. And I will just move forward with a question. Why are so many doctors quick to dismiss higher ketones? I routinely get questioned and told not to check ketones unless my son is sick or symptomatic. However, he frequently has elevated ketones.
Okay, so another difficult question.
Yes.
Doctors are not good at admitting they don't know something. And one of the problems is, oftentimes if we don't know something, we'll just call it normal. And that's what's happening in ketotic hypoglycemia. The other thing, as you heard from Terry earlier, ketones are a normal part of physiology.
Yes.
But that's when people are sick. That's when people are stressed. they should not be happening on a normal situation. So because it is a normal product, it gets misinterpreted as being normal all the time instead of realizing that the levels are too high. So that's why I think doctors dismiss it. It doesn't make it right. And I hope that after Kamal's research is published, people will realize it's not a normal manifestation when people are well.
Thank you, David. And I just have one more. Does having ketotic hypoglycemia make it difficult for children to gain weight, and why?
So, yes. So one of the hallmarks that's always been known is that people with ketotic hypoglycemia oftentimes are skinny, and they're also shorter than they should be in many of the children. And that's because when people are getting hypoglycemic, they'll use any fuel they can to try to maintain the blood sugar. And one of them is going to be fat so they're going to use fat and protein as fuel. So that's going to lead to what should be storage forms of energy being used all the time. Chronic ketosis also causes low effect growth. So what I have seen is that when we treat kids with ketotic hypoglycemia, they often get a massive growth spurt. And oftentimes they end up much taller than their parents because their parents were also affected by being carriers. And maybe they ended up shorter than they should have been. A lot of my ketotic hypoglycemia patients are a lot taller than their parents after they've been treated.
Thank you so much, David. And then a question about monitoring. How important is ketone monitoring in the home? Because especially a lot of the families in the United States gets denied when they are applying for a ketone monitor.
Unfortunately, the healthcare system in the United States is broken, and it's a big problem. I don't have a way to solve the fact that insurance companies won't pay for this device that I think is critical. To me, the ketone monitoring is more important than the blood sugar monitoring because it's the ketones oftentimes that are causing the symptoms. What I recommend is trying to get a sample to try it. And then what I do is if I have somebody with ketotic hypoglycemia, I will send them home with a sample kit and strips and get them to document in the morning high ketones. Once we have it documented, then we can oftentimes get the insurance companies to pay for it. But I think it's important whenever to get doses right. I like for people to monitor in the morning to make sure we're not outgrowing doses and keeping levels appropriately low, and around activity, because that's how I can get the dosing of cornstarch and protein right.
Thank you, David. And now we have a question from Sonia. She's asking, why is it then when a child goes outside and plays in the snow that the blood sugar will quickly drop?
Okay, so those people who know me know I'm from Miami Beach. So I have to question why anybody would want to go out in the snow. And I saw in those videos earlier, all this pictures of children playing in snow. I'm not sure I get that, but the problem with snow and cold weather is that the body has to burn energy to stay warm. If somebody, especially is in the snow where they're getting wet, that's going to cause even more heat loss, which is going to cause more energy demands on the patient. So we know that the problem. So my recommendation is everybody should move to Florida and go to the beach instead of the snow.
Thank you for that, David. Then we have a question from Maria. She's asking, should we be especially aware treating a neonate of a mom with ketotic hypoglycemia? Should we make any special measurements for the delivery plan for this child that's going to be delivered of a mom with ketotic hypoglycemia?
Yes, I mean, I think that anytime a mother has it or there's a family history of it, we should be monitoring the children. They're in the Pediatric Endocrine Society guidelines, which Paul led the team in publishing. If there's a family history, we should be monitoring children. And there's a recommendation for making sure that children can tolerate a short fast without getting hypoglycemic. As you heard earlier, though, ketone monitoring is not reliable in the newborn period, right? Especially in the first day or two. So we can't depend on us measuring the ketones to tell us if a child's going to have problems. It's going to be just a
Amazing. And then I have a question from Rima. Does exercise or therapy make children more prone to developing ketotic hypoglycemia?
yes, but doesn't mean it shouldn't be done, because we can prevent ketotic hypoglycemia. We can prevent it with supplements like cornstarch, like protein supplementation. We saw the video earlier of that fantastic young lady who's a biker and can also use continuous feeds. There are many ways to do it. We just have to cover the increased activity with extra support. And so I've had patients with ketotic hypoglycemia do marathons. We just have to give them more energy because they can't make it themselves.
Thank you again, David. And I am just looking to see if we get everything covered. I think I have a question about what are the benefits of G-tubes in ketotic hypoglycemia, especially for children who are hard IV to get an IV placed. So what is the pros to get a G-tube?
So getting a G-tube is an individualized decision. Every family has to look at its own situation to decide whether a G-tube is indicated or not. Some children, if they just get put on cornstarch and protein, do very, very well. Some children get into problems with hypoglycemia and ketosis so quickly that they need to get a rescue, or if they're very in a rural area and they can't get access to an IV quickly, or if someone can't get an IV. These are all factors that have to be considered. I can't give you a simplified answer about whether someone should get a G-tube. This is something that we recommend people talk about and look at their situation inside.
Thank you so much, David. And I will just keep firing away with all the questions. So this question is, should all patients with IKH be put on a ketogenic diet?
So I don't think anybody should be on a ketogenic diet if you have ketotic hypoglycemia. Because if someone has ketotic hypoglycemia, that means they're getting high ketones. If you put people on a ketotic diet, you're going to make the ketones worse. There are situations, as again you heard earlier, where a ketogenic diet should be done. That's typically for people with seizure disorders, or people with glycogen storage disease type 3, where their heart is big and you have to really cut the glycogen. But ketotic hypoglycemia is not a reason to put someone on a ketogenic diet, to my mind, because you're just going to exacerbate the situation.
Thank you, David. And then I have a question from Elena. She asks, if a patient is genetically negative for all GSDs, but has symptoms and clinically consist with GSD 0 and a family history of IKH, should a clinical diagnosis of GSD be considered? If so, how?
Again, I will just emphasize we must treat the patient. GSD is a subset of ketotic hypoglycemia, but it's not everything. You're going to hear upcoming talks about other types of ketotic hypoglycemia. Excuse me. Oftentimes, it manifests looking like GSD type 0. GSD type 0, the storage where I talked about earlier, it's about 4% of ketotic hypoglycemia. But it's going to look, many children are going to look that way, and you have to treat the patient. It is not normal for blood sugars to be falling low, under 3 or under 50. Not normal for children to be getting ketones over 1. If that's happening, we have to treat them. I don't care if we don't have the diagnosis. And I used to classify it as if someone gets hypoglycemia overnight, in my mind, that is consistent with a glycogen storage disease. We may not be able to answer it with the 16 types that we have right now, but we're also learning about new types all the time.
Thank you so much, David. I know that was a difficult question to answer, but I have a question from the Faroe Islands. I have a question from Kitty. She's asking, is there a correlation between nose bleeding and low blood sugar with high ketones?
So first of all, I would like to say hello to all my friends on the Faroe Islands. Not being able to go visit you guys is one of the biggest things that I'm missing, that and my team, and my patients. So I miss all my friends on the Faroes.
And I know that they miss you so much, David. So they are so excited to be here with you.
So I will say that nosebleeds are common in many of these disorders, because when somebody is hypoglycemic and ketotic, they're going to have the acidosis and the high triglycerides, which come from the body breaking down fat, can affect platelet function. And we see that in many of the metabolic disorders. So it is something that we've seen frequently in the patients that I would see. And it's usually a sign that their control is not good enough, that we're probably getting ketotic and high triglycerides.
Thank you so much, David. And then I will have a question from Lorelei. If my son has ketotic hypoglycemia, but my daughter don't show those symptoms, are they then likely carriers, and should they be on cornstarch and protein? I have 8 kids, and even my husband thinks they are fine.
No, because even if the classic situation that is glycogen storage disease type 9, where the males have it and the females may or may not have it, but there's only a 50% chance in that situation that the female would be a carrier. So you treat, again, whether it's the doctors or the families, we treat the patient. If someone is not manifesting symptoms, we don't need to treat them. But if they're getting hypoglycemic and ketotic, then we treat them.
Thank you so much. And then I have a question about the age groups. This is from Mackenzie. She's asking, how do treatments differ in younger kids versus older kids, such as teenagers? Is there a difference?
So the younger a person is, the more likely they're going to have symptoms and get into issues. But this, I will preface this by saying this is a personal opinion. Many of the other physicians may disagree with me. But if a person has ketotic hypoglycemia, I don't think that they fully ever outgrow it, no matter what the textbooks again say. I find that the older people, even if they're not getting into acute episodes, still benefit from cornstarch and protein, because their sugars are getting low. They're getting ketotic when they exercise and they don't have great stamina, and they do better and they feel better when they're treated. So I continue to treat people as they got older. It's just they're not getting into episodes as much as they did when they were younger.
Thank you so much, David. And now I think I have a doctor asking you questions. So I have 2 questions from a Peter. Peter is asking you, this question is for Dr. Weinstein, about GSD in heterozygous patients considered carriers are experiencing symptoms. Is it worth considering whether the hypothesis would be to interfere synergistic heterozygosity rather than symptomatic carrier syndromes? Sorry for my pronouncing.
Yes, no, I understand. And
Right.
Absolutely. So synergistic heterozygosity is something also that Terry Dirks has been very interested in. I want to make sure he gets credit. We both have noticed that we had patients who would come back as carriers for a particular disease. But when we did more testing, they were carriers for 2 different diseases. And again, the textbooks will say that people who are carriers don't have the disease. But what we found is that people who are carriers for 2 different energy problems do manifest symptoms. And that's, so I think many of the truly symptomatic carriers may have synergistic heterozygosity. This feels evolving. I don't really pursue it in everybody unless the person is really having problems or very symptomatic. If it's just mild hypoglycemia, then I'll just treat. Again, treat the patient.
Yes. Thank you. And then I have a question that is relevant for a lot of the families in KHI. This is from Marissa. She's asking, what is the treatment for kids with ketotic hypoglycemia who don't tolerate cornstarch?
So another part of the treatment, I think, is protein, high protein. You already heard, again, previously today, that low alanine occurs frequently in children with ketotic hypoglycemia. Low alanine is an amino acid from protein. So the body overutilizes protein to try to maintain the blood sugar. So I treat all my patients with protein, a high protein diet. You're going to hear about this, I'm sure, from Kathy Ross tomorrow. And what we do is we aim to normalize a blood test called the prealbumin, which is a storage form of protein. So protein's a good way to treat people. For people who don't tolerate cornstarch, we also will try other starches like tapioca starch, which is another one. So there are other alternatives, or you can do a complex carbohydrate diet, and that also can help.